Hi, this is Dr. Bethany Murray. We're going to be talking today about neurotransmitters in the body and how those are important in psychiatric and mental health nursing. There we go. Okay. So just a brief anatomy review. The central nervous system consists of the brain and the spinal cord. The peripheral nervous system are all of the neurons that innervate muscles and organs in the rest of the body. As you know, sensory neurons travel from the body back to the brain, where they are then interpreted and messages are sent back down from the brain and the spinal cord into the rest of the body. These messages are sent by way of something called neurotransmitters. Neurotransmitters are natural chemicals active in the spaces between the neurons. They generally travel in one direction from one cell, which we'll call the presynaptic cell, or presynaptic nerve cell, down through a synaptic terminal and then to the postsynaptic nerve cell. You can't quite see that on the slide here, but you have to imagine. So this is the way that cells communicate with one another, is through neurons, neurotransmitters. We're going to talk a lot about neurotransmitters in this course because they're very important for understanding psychiatric medications. Any place in the body that we have nerve cells, we have neurotransmitters. Psychiatric medications have three main types of activity. They either act against or in concert with a neurotransmitter. So they agonize, which means they might occupy or bind to neurons by imitating a neurotransmitter, or they antagonize or block neurons and neurotransmitter receptor sites. Then the third way that psychiatric medications will work is by altering or interfering with enzymes that will break down neurotransmitters in the body. And when you interfere with the enzymes that break down and metabolize the neurotransmitter, then you make more of that neurotransmitter available. Okay? So these are the chief neurotransmitters: epinephrine, norepinephrine, serotonin, dopamine, the muscarinic receptors, which consist of acetylcholine and nicotinic acid, GABA or gamma-aminobutyric acid, glutamate, endorphins, histamine, and lastly, endocannabinoids. I'm going to want you to know a little bit of something about all of these neurotransmitters. But don't worry, as we talk it through, it becomes clearer and easier to understand. So I'd like to draw your attention to a handout that I put in Canvas for you. Okay, this handout looks like this. It says primary neurotransmitters. And you can see it's a 2-page handout. I developed this last fall and edited it this spring. And this breaks down the primary neurotransmitters into some of their characteristics. For example, if we look at epinephrine, we can think of that as a fight or flight neurotransmitter. It is adrenergic, which means that it activates the sympathetic nervous system. The sympathetic nervous system is our branch that tells us to run, flee, or get out of danger. Okay? When you agonize, which means you turn on or you imitate the sympathetic nervous system, you are agonizing alpha receptors and beta receptors. Epinephrine is released by the adrenal glands that sit on top of the kidneys in response to perceived danger. It increases your heart rate and blood pressure. It causes blood to shunt to the skeletal muscles and the bronchiole to dilate so you can better oxygenate your lungs. And the liver will react then to epinephrine to produce more glucose for energy through a process called gluconeogenesis. Clinically, we use epinephrine agonists, which is actually epinephrine, to treat anaphylactic reactions or allergic reactions, and to relax the smooth muscle of the bronchiole. So there's less wheezing and less bronchial constriction. We also use epinephrine directly as a medication for cardiogenic shock to increase heart rate and blood pressure. Okay. So in the parasympathetic nervous system, we have a neurotransmitter called acetylcholine, ACH. And you might think of the parasympathetic nervous system as the rest and digest nervous system. So instead of getting us out of danger into a place of safety, the parasympathetic nervous system is the hibernation, digest food, relax, rest. Everything dilates. Smooth muscle slows down and relaxes. Blood vessels dilate rather than contract. Okay. The cholinergic or parasympathetic nervous system is divided into two branches, a muscarinic branch, which is the most important for discussing psychiatric care, and a nicotinic branch, which only innervates skeletal muscles. When you agonize or imitate the cholinergic nervous system, your heart rate and blood pressure go down, your digestion improves or increases, your urinary excretion increases, that's a muscarinic effect, your bronchi constrict, salivation increases, and skeletal muscles can contract. And you can see after each statement whether that's muscarinic or nicotinic side effect or effects. Okay? Most of the time, we do not directly agonize the cholinergic nervous system. We antagonize the cholinergic nervous system. So in some exceptions, we do agonize the parasympathetic nervous system. And one example, which we'll come back to later on when we talk about dementia, is the drug donepezil. Donepezil is used in Alzheimer's disease to increase the amount of acetylcholine available to the brain. It works by acting on an enzyme that breaks down acetylcholine so that less is broken down and more is available. We also sometimes will use anticholinergic drugs to treat Parkinson's disease. And we have a direct agonist for a cholinergic drug for glaucoma. And the only current use really for the nicotinic acid agonist is in a disease called myasthenia gravis, which has to do with skeletal muscles. Many anticholinergics have many clinical uses. So most of the time in psychiatry, when we say a cholinergic drug, we're talking about an antagonist or an anticholinergic drug of the muscarinic side. So if you look up here at the things that the cholinergic system does, if you think about the opposite of these, antagonizing or reversing these, okay? So an anticholinergic, anti-muscarinic activity of a drug is going to cause the heart rate and blood pressure to go up, digestion to slow, gastrointestinal contractions, peristalsis will slow, urinary excretion will slow, the bronchioles will dilate. So one of the asthma medications is anticholinergic. The mouth dries up, salivation decreases, tear production of the eyes decreases, and there's minimal effect on skeletal muscle with anticholinergics because that's in the nicotinic side of the system. Okay. Another neurotransmitter that you probably already know about is the endorphin. And the endorphins is our body's natural opioids. When we are in an emergency situation or are injured, we do release some natural endorphins in the brain. So they allow us to have a decreased pain sensation. We produce endogenous opioids in the pituitary gland and the hypothalamus of the brain. And they produce a generalized sense of well-being and a decrease in pain. Clinically, we mimic or agonize endorphins for pain relief using opioid medications, both natural and synthetic. They're also important in talking about opioid drugs of abuse. We antagonize the opioid receptors with things like naloxone or Narcan and naltrexone or Revia, which is an oral form of naloxone. Now let's look briefly at the GABA system, gamma-aminobutyric acid. Most of us just say GABA. If you are using a drug that increases or agonizes the neurotransmitter GABA, then you are making the neurons, the nerve cells, less sensitive. So GABA is an inhibitory neuron. It inhibits the reactivity or the sensitivity of the neurons. It diminishes action potential to the neurons. It reduces neuron responsiveness. So you can kind of think if you're going to reduce neuron responsiveness, you're going to reduce the likelihood of seizures, twitches, tremors, shakes, and in psychiatry, anxiety. And in fact, benzodiazepines do have as their chief source of action to agonize or increase the level of GABA within the neurons. Okay. Antagonists, there's really only one GABA antagonist that we use. It's called flumazenil, and it's a benzodiazepine reversal agent. And we'll talk about that with the substance use disorder slides. Glutamate is the flip side of the coin of GABA. If GABA is inhibitory, glutamate is excitatory. Glutamate stimulates the action potential of neurons, of nerve cells. It excites neurons. Too much glutamate can be toxic to neurons. It increases the neuron responsiveness to stimulus. If you want to agonize or imitate glutamate, you can do that using ecstasy, or you can do that using a new product for major depression called S-ketamine, which is basically a derivative of ketamine. If you want to antagonize glutamate, you can treat chronic pain by decreasing glutamate responsiveness. So you're decreasing the irritability and action potential of the neurons. You can also treat Alzheimer's disease by one drug which decreases glutamate. The theory is that glutamate can be toxic to the neurons at too high a level, so memantine will decrease the amount of glutamate available. And lastly, you can treat epileptic seizures and reduce that irritability and action potential of neurons with drugs like lamotrigine and valproic acid, which are antagonists of glutamate. Now let's look at page 2. You'll notice on page 2 across the top, there's a bar that says monoamines. These four neurotransmitters rather, are called monoamines. They are metabolized by an enzyme called monoamine oxidase. That becomes important when we learn about the category of antidepressants called monoamine oxidase inhibitors. If you inhibit an enzyme, you slow down the breakdown of the neurotransmitter that it's targeting. So when you inhibit monoamine oxidase, you subsequently raise these four neurotransmitters in the brain. Okay, so the first neurotransmitter is dopamine. Dopamine is an extremely important neurotransmitter in the psychiatric world. We talk about dopamine imbalance, too much dopamine, too little dopamine. We enhance dopamine with drugs. We block dopamine with other drugs. We can't stop talking about dopamine in this field. So dopamine is actually a sympathetic nervous system stimulant. It's an adrenergic neurotransmitter. It's used for fight or flight response. That also should tell you that some of the actions of dopamine are up here. It increases heart rate and blood pressure. Bronchioles dilate. Okay, so we have to think of dopamine as an activating neurotransmitter. It comes in our bodies from the amino acid tyrosine, which is predominantly consumed through animal proteins and also secondarily through legumes and other protein sources in vegetables. Dopamine has essential responsibilities for muscle and motor control in the motor cortex of the brain, concentration, focus, and executive functioning of the cerebral cortex, or the thinking part of the brain, euphoria, pleasure sensations, and promotion of substance use and addictions in parts of the brain. In the peripheral nervous system, dopamine is a vasodilator, which can reduce hypertension and cardiac afterload. And clinically, we use dopamine agonists to treat the disease of Parkinson's disease, which is a dopamine deficiency disorder. We actually directly give a medication called levodopa-carbidopa to reverse the symptoms of Parkinson's disease. We also directly promote dopamine when we're treating attention deficit disorder. The attention deficit disorder or ADHD stimulants all work by promoting the release of dopamine. When we want to work against or antagonize or block dopamine, those are all of the medications that are used for schizophrenia or psychotic disorders. So it's very important that you learn how dopamine works in the brain and the relationship between movement disorders like Parkinson's disease, attention or thinking disorders like ADHD, and psychotic disorders like schizophrenia. Next, we'll talk briefly about norepinephrine. It's a sympathetic nervous system neurotransmitter, which is related to, but not the same as epinephrine. It is an agonist of just the alpha receptors in the sympathetic nervous system. It's synthesized from dopamine as well. It increases heart rate and blood pressure. some activity in reducing the perception of pain. If you increase norepinephrine, you can reduce anxiety, reduce depression, and improve focus and concentration. So you can kind of see some of this has a correlation with dopamine and some is different. Drugs that agonize or mimic or imitate norepinephrine can treat depression and anxiety and decrease pain perception, and in fact, treat attention deficit disorder. We have a couple of products on the market that are not dopaminergic stimulants, but rather norepinephrine promoting agents to treat ADHD. If we want to go against dopamine or norepinephrine, if we want to block or antagonize norepinephrine, we can reduce high blood pressure and reduce impulsivity and impulse control disorders. The next very important neurotransmitter, and one that you've probably heard the most about, is actually serotonin. Serotonin is, again, an adrenergic. You'll notice how all three of these are adrenergic and activate in the sympathetic nervous system. That means that all three of these are activating neurotransmitters. It's synthesized from amino acid tryptophan. Tryptophan must be consumed in our diet. Major sources of tryptophan also include animal byproducts. You may have heard of turkey being high in tryptophan. Milk is also high in tryptophan. And then there are other products that you can get consumed that contain tryptophan. And they stimulate neurons in the central nervous system as well. If you imitate or trigger or activate serotonin, the neurotransmitter serotonin, you can treat depression and anxiety. You can combine it with a norepinephrine neurotransmitter drug in a serotonin norepinephrine reuptake drug. You can treat migraine headaches in the central nervous system. So sumatriptan and all of the triptans are migraine headache treatment medications. You can also manage pain with some serotonin. Okay. And unfortunately, you can get too much serotonin and have an experience called serotonin syndrome, which is characterized by rigid muscles, eye jerking motions, tremors, hyperreflexia, agitation, sweating, dilated pupils, very uncomfortable flushed skin, and even elevated body temperature. Serotonin syndrome is typically not a life-threatening syndrome, but it's a quite uncomfortable phenomenon, and it may require some medical treatment. If you antagonize serotonin in the central nervous system, within the brain, you actually can reduce nausea and vomiting in the drug called ondansetron or Zofran, which is used in chemotherapy, pregnancy nausea, and other forms of nausea. Then the last of the monoamines is histamine. Okay, we know a lot about histamine. Histamine is a cholinergic neurotransmitter. It's no longer sympathetic nervous system. It's now on the parasympathetic nervous system side. You can find histamine receptors throughout the body. Histamine type 1 receptors are predominantly found in the brain, and histamine type 2 receptors are predominantly found in the gut. But we have histamine receptors every place in our body because histamine is intricately involved with allergic reactions. So when we encounter an antigen, there's a chemical process that causes a massive release of histamine in our bodies that set up an allergic reaction and inflammatory reaction. The histamine 1 receptors in the brain promote wakefulness. Histamine 2 receptors in the gut promote gastrointestinal secretions. So if we want to imitate or activate histamine, there is one medication we use in psychiatry called modafinil that is a wakefulness promoting agent. It's predominantly used for people who struggle with drowsiness because of sleep apnea, obstructive sleep apnea, shift work sleepers, or the disease called narcolepsy. If we want to antagonize histamine, we commonly call that an antihistamine. Antihistamine or antihistamine, and I'm sure many of you have heard of or used an antihistamine before for seasonal allergies or other over-the-counter uses. An antihistamine, an antagonist, will reduce the immune system's response to an antigen or an allergic reaction. It will be used off-label to treat insomnia because of the sedation side effect. You'll notice that histamine receptors promote wakefulness, but antihistamine promotes sleepiness. And we can also use antihistamines to help reverse some of the involuntary muscle or motor movements that can occur secondary to antipsychotic medications. And we'll learn a lot more about that later on. Lastly, I'm going to just briefly mention the endocannabinoid system. This is an area of increasing interest and increasing research. We have endocannabinoid receptors in both the central and the peripheral nervous system. Most of the research is looking at the central nervous system. Cannabinoid receptor agonists can reduce pain perception, including menstrual cramps, reduce nausea. We do have a form of medication, endocannabinoid receptor medication, that's used for cancer chemotherapy treatment and the nausea associated with that. We can reduce inflammation. We can reduce seizure activity and neuronal irritability, and reduce eye pressure in the disease of glaucoma. The medical use, though, of the cannabinoid neurotransmitter is limited by its central nervous system effects of euphoria, altered sensory perception, tachycardia, concentration and memory problems, and secondarily then hunger and sedation. So we still have a long ways to go with research into the clinical usage of cannabinoids and the endocannabinoid neurotransmitter. Okay, I'm going to go back to our slide deck now. There we go. So now you should have some familiarity with epinephrine, norepinephrine, serotonin, dopamine, acetylcholine of the anticholinergic system, GABA, glutamate, endorphins, histamine, and the endocannabinoids. Okay, this next few slides will just repeat the information that I've just given you from the handout. Epinephrine is an adrenergic sympathetic nervous system agonist, increases your focus, concentration, muscle activity, very important to use for allergic reactions and anaphylaxis. We don't use it very much directly in psychiatry. Norepinephrine is also a sympathetic nervous system agonist. It reduces pain perception and helps to alleviate anxiety and depression in psychiatric care. So we do have quite a few medications we use that are norepinephrine specific. Lastly, which is not on this slide, is we do now have several attention deficit disorder medications that are norepinephrine specific. Serotonin, first line treatment for depression and anxiety disorders. And in the medical world, we also have serotonin medications to treat migraine headaches and nausea. Dopamine is a very important sympathetic nervous system stimulant involved with motor control, concentration, executive functioning, involved in cardiology to reduce hypertension and cardiac afterload, and rapidly lower blood pressure in an emergency setting. Involved in Parkinson's disease, which is a primary deficiency of dopamine. Involved in schizophrenia, in which we block dopamine or antagonize dopamine to improve the symptoms of schizophrenia. And involved in attention deficit disorder, when we actually use medications that promote the release of dopamine from presynaptic neurons in the brain in order to have more dopamine available for executive functioning. Acetylcholine being our primary parasympathetic nervous system or cholinergic neurotransmitter. And most of what we talk about is anticholinergic, but we do have a few instances that are pro or agonist of cholinergic. Alzheimer's disease being one of those where we want to promote acetylcholine. And then we have a couple of medical diseases that we're involved with acetylcholine. GABA, glutamate, endorphins, and histamines. So all of these are on your handout, and I would refer you to use that handout as we study. As we go forward and I talk about medications, I will refer to those medications as dopaminergic or dopamine agonists, serotonergic, serotonin reuptake inhibitors, histaminergic or antihistamines, anticholinergic. And that's where all of that language is coming from, this discussion of neurotransmitters. Okay. So now we're going to move into looking at an exemplar of a degenerative neurological disorder. Here's 5 degenerative disorders that you can think about: Parkinson's disease, myasthenia gravis, multiple sclerosis, amyotrophic lateral sclerosis or ALS, and Huntington's disease. We're really just going to focus on Parkinson's disease because it has the most significance when we're talking about dopamine neurotransmitter and dopaminergic drugs. Okay, so Parkinson's disease generally affects people that are age 50 and over and progresses slowly. This is a naturally occurring disease. It's not secondary to an external stimulus, such as a virus or a trauma, at least not that we know of. Parkinson's disease is basically an imbalance of dopamine and acetylcholine. So it's an imbalance in the sympathetic nervous system of dopamine and the parasympathetic nervous system of acetylcholine. If you look at the scales on the left, we want to have some kind of a normal amount of dopamine and acetylcholine. What happens in Parkinson's disease is you lose dopamine. So that's represented by the scales going up. You're losing dopamine and you're having too much acetylcholine. So you're having too much cholinergic effects. Okay. Degeneration of the neurons that supply dopamine to the brain result in reduced dopamine in the nerve terminals. And this becomes extremely important in the motor cortex of the brain, where movement and coordination in the body are involved. As the disease progresses, messages from the brain that travel down the neurons into the body and tell the body how and when to move are delivered much more slowly, and motor activity overall slows. This reduction in dopamine, combined with an excess of relative to dopamine, an excess of acetylcholine, ACH is an abbreviation for acetylcholine, causes the symptoms of Parkinson's disease. So the goal is to restore the balance. And you can do that in 2 ways. You can do that by increasing the amount of dopamine and or reducing the amount of acetylcholine. Drugs used to treat Parkinson's disease predominantly increase dopamine levels, stimulate dopamine receptors, extend the action of dopamine in the brain, or prevent cholinergic receptors, acetylcholine. Please ignore the pyknotics. I did learn, this is an animation to help learn pharmacology. I did learn that the pyknotics for students will not be activated until September 1st. So you can just, you're welcome to look at those, but you won't have a free account from the university until September 1st. Of 2023. So the prototype drug for Parkinson's disease is called Sinemet or carbidopa-levodopa. So what do we need to know about carbidopa-levodopa? It's a combination drug used specifically for treating Parkinson's disease. It's oral. It has an onset fairly quickly, and it has a duration of action for, I think that's a typo where it says onset 1 to 2 months. I think that means maximum effect 1 to 2 months. Okay. It works by diffusing levodopa into the central nervous system, where it's converted directly into dopamine. However, levodopa will convert very quickly. When you take an oral tablet, it is absorbed through the gastrointestinal tract into the bloodstream. It has a first pass through the liver, where some of it is partially metabolized, and then enzymes in the liver will very quickly convert levodopa, carbidopa. They'll very quickly break down levodopa, metabolize levodopa. So carbidopa is actually used to prevent the conversion of levodopa into dopamine in the body and let it stay as levodopa until it can cross the blood-brain barrier and get into the brain and then convert into dopamine in the brain. We don't want to waste the dopamine, the converted dopamine in the body where it's not needed, because this is a disease of dopamine deficiency in the brain. So we need the oral medication to make it through the blood-brain barrier and have maximum benefit in the brain, if that makes sense to you. Okay, there's no real contraindications to carbidopa-levodopa. It does have some side effects, predominantly gastrointestinal, nausea, vomiting, loss of appetite, sometimes some abnormal movements in the body. The biggest problem that we have is we are providing the brain with extra dopamine, and sometimes excess dopamine can lead to psychosis, hallucinations, delusions, disorientation, confusion. Okay. Okay. So to maximize the benefits of carbidopa, levodopa, and minimize the conversion and loss of the drug in the body, it's best to take it on empty stomach. It is a highly protein-bound medication, so we want to try to not have protein or vitamin B6 at the same time. You want to not take this medication with a meal. Again, take it on empty stomach at least 30 minutes before a meal. It's typically taken several times a day, about 3 times a day, and you always want that to be 30 minutes before a meal. Okay. So we'll just kind of stop and do a challenge question. Do you recall what is the rationale for giving levodopa and carbidopa together? Is it because the medications are synergistic and make each other work better? Is it because the carbidopa facilitates peripheral uptake of the levodopa, the peripheral nervous system? Is it because the carbidopa prevents the levodopa from crossing into the brain? Or is it because the carbidopa prevents the levodopa from being broken down or metabolized in the periphery of the body? What do you remember? Okay, right. The carbidopa prevents the levodopa from being broken down to dopamine in the periphery of the body where it's not needed. It preserves it until it crosses the blood-brain barrier, and then it can convert and it can metabolize into dopamine in the brain, therefore increasing the amount of levodopa available for the central nervous system. So in summary, neurotransmitters are naturally occurring chemicals that carry messages across neuronal synapses. Neurotransmitters may agonize or antagonize a neuron. They can activate or turn on a neuron. They can block or stop a neuron. Psychiatric medications target these neurotransmitters in the brain, in the central nervous system, but they can have incidental peripheral nervous system activity as well. And that's typically where some of the side effects or adverse effects come from. Psychiatric medications chiefly act by agonizing postsynaptic neurons, neurotransmitters at postsynaptic neurons, antagonizing postsynaptic neurons, promoting the release of the neurotransmitter from the presynaptic neuron, or altering the activity of the enzymes that metabolize neurotransmitters. I know that's a lot, but the really important thing to remember is psychiatric medications work in the brain, they cross the blood-brain barrier, and they work on either neurotransmitters that act on neurons or on the enzymes that break down the neurotransmitters. Once you know the neurotransmitters, then you can easily predict what the activity of a psychiatric medication will be. Parkinson's disease serves as an exemplar of a neurodegenerative disorder that is related to the neurotransmitter dopamine. In fact, is a dopamine deficiency disorder. As we go forward, we'll talk about other disease exemplars that are dependent on dopamine, the neurotransmitter dopamine, and how they're expressed and treated. So thank you very much for your attention. I hope this video has been helpful for you, and I look forward to seeing you in class later on. Bye-bye.